Okay, it is 11 o'clock and it looks like the waiting room is cleared. Wayne, did you want to call roll for the members logged in?
Sorry, I had to unmute myself. Just was calling to make sure that we had TAC members that were available. I think Chairman Terry Skaggs is signing on. I was just talking to him just a minute ago. So let's maybe give it another minute or so, and I think Terry will be able to kick off the meeting.
Absolutely.
Okay. Aaron, if you'll just watch for Terry when he comes in, and I'm contacting another member as well.
I believe he just logged in, so he should be. Let me scroll and see if he's.
And also Sarah McIntosh. I've just contacted her as well.
Okay, I do see that Terry is logged in.
Okay.
Yeah, I'm here. I'm sorry.
Sarah's here as well. I was having technical difficulties.
Okay, Terry, if you would like to start, it looks like the waiting room is cleared.
Right.
And
I apologize for being late. I was buried in a budget and just totally forgot it. my mistake. Do we have all TAC members on here? I'm scrolling down. I see Janine, I see Adam, I see Sarah. I think we do have all of the TAC members on. Is Jay Trumbo on?
I don't believe so, Terry, but I'm going to give him a quick call right now just to remind him.
All right. With all but Jay on, we do have a quorum on our committee. So the March 8th, 2023 minutes were submitted to each of the TAC members. Does anyone have any changes or any questions on those minutes? Hearing none, does anyone disagree with approval of the minutes? If not, we'll assume the minutes are approved. All right, item 1, or item A, I guess, under issues under discussion is the bridge to rebasing and the inflation update. I know we did get the information this week or actually last week from the governor's press conference. And I think Sarah and Jay had a conversation sometime late last week while I was out and on vacation. Would somebody from the cabinet like to just give a brief update on what the determination was for the July rates, and we'll quickly put that one to bed.
Steve Bechtel, Chief Financial Officer for Medicaid. Yeah, we had a meeting with the association and a few of the people that you mentioned last week to kind of go over the details of that. I'll try to do it as a high level type of discussion for today. But if we need to get into a little more detail, just let me know and we can set us some side another time to discuss or something. But basically, sure. Every year on July 1st, per the reg, we're supposed to adjust for inflation. And so the last couple years or last year, we did full inflation, and we committed to you guys earlier this year that we were going to provide full inflation again this year. Mm-hmm. And we were going to use the same historical market basket that we've used for the price and the RS means for the capital, the most recently published rates. So the most recently published rate for the inflationary adjustment for your from the market basket that adjust your price, your standard price is 3%. That was what it was in April, I believe it was. So that was what we were looking at. We had a meeting with, and then the RS means was 8 point, I think it was 9 something or 6494. I can't recall.
8.94.
Yeah,
Yep.
though that was from the January publication of the RS means. So we were going to do full inflation for that based off of that. But we had a meeting. I had a call with Wayne and Jay, and we were talking about the inflationary adjustments. And so then trying to figure out what we could do outside of that. And then after that meeting, and while we were looking up, we had a meeting with the association with Betsy and her staff there. And then we also received some letters from some of the CEOs across the state asking for what they call a bridge of, they know we're going to rebase 7.1, but what can we do? We're having, we listened, we heard that a lot of them were having financial issues now, and 7.1 of 2024 may be too late for some of them. So we were trying to figure out what can we do without having to do a SPA or a reg change, because that would take, a SPA takes at least 90 days. A reg, I don't know how long that would take anymore. So we're trying to figure that out. And so I came across an article from McKnight's article from April 4th that the CMS kind of used the same market basket that we use. And the market basket is a projection of what inflation is going to be over the next year. And so what we've done is, and let me just clarify the press release that went out. We're not going to be doing retroactive rate adjustments. What we've done is we've gone back for those years and looked at what the actual inflation was and compared it to what the inflationary adjustment we made. And what we're trying to do is a catch-up type of thing, which is what Medicare did on your Part A rates. And so we just mirrored their process, CMS's process on the Medicare rates, and applied it to your all's process to try to address this financial concern. So that's going to be an additional, on top of the 3%, you're going to get an additional 6.5% on top of that. And that's where that came up. And that's going to, with all of that combined, the 3% plus the 6.5 and the means, it was going to be estimated on 5 million. We're estimating 5 million bed days, right? So if there's more bed days, it could be higher. But on 5 million bed days, we're estimating that to be an increase of about 99.6 million for the across all nursing facilities in aggregate. Now, some may get more, some may see a bigger impact than others. It depends on really your bed days that you have, but in aggregate, we're looking at a $99.6 million increase to the rates. There's questions on how we funded that, but how we're funding that is, when we do our budget forecast, we always forecast for inflation, and the inflation that we tried to forecast in our budget preparation. If you recall, we had to do that like 2 years ago, but I think we adjusted for like around 4% to 5% each year. And so when we didn't do that, so there was room there in our budget where we did not have to ask for additional appropriations to get this accomplished. So we figured this was the best way to do it. Now, those will be applied to your 7.1 rates. Going from 7.1 forward, and that's how we'll do it. Now, you're not going to get an influx of cash right at the first, but as you build those claims, you'll get higher reimbursement, and hopefully, as the months come by, it'll help ease some of the financial strain. I know it won't resolve all of them, all of your all's financial issues, but it'll hopefully ease it while we're waiting to do the rebasing, and hopefully, when we do rebasing, that will hopefully bring everybody up to cost at that time.
And I know it's probably been said already, but I was vacationing last week and haven't had opportunity. We greatly appreciate everything that you've done, Steve. Okay. like you said, it may not be enough for everyone, but it's a significant move above inflation to try to get that bridge built to next July when we do the full rebasing.
Yeah. And I can't take all the credit, you know, one, I have to thank the governor and the administration for the approval. You know, they're the ones who gave the ultimate approval. And so I appreciate them and what they know how important this is for the members that we serve. But I can't thank Myers and Stauffer enough, as well, as they've been helping me doing a lot of the analytical work. So, and my team as well. So,
and again, we greatly appreciate it. All right, thank you for the update. Any questions from the TAC members on the update? All right. The next item on the agenda is a excuse me, a Medicaid unwinding update specific to the nursing facilities. Just can you give us an update on how the unwinding is going? I mean, I know we're in the process of doing the renewals and all of that. Just if somebody could give us an update, I would appreciate it.
Sure. Good morning. This is Veronica Judy Cecil, Senior Deputy Commissioner for Medicaid. Nice to see everyone. I did prepare a couple of slides, and we'll send these to the group and post them afterwards. You're right. We are in the throes of Medicaid unwinding and the restart of renewals. And we are, you know, we passed May, we're into June and July renewals. At one time, we'll be working on 3 different months and potentially 4 or 5 based on a reinstatement period that I'll talk about. But this is just a snapshot of the caseload distribution. This is at the case level, which means that there could be 1, 2, 3, 4, 5 members of the household that are in the case. So we monitor based on the caseload because that's how we can help provide oversight on the workforce and making sure that we're kind of monitoring that they're not getting overwhelmed. I wanted to point out, because this is a bit of new information, in July and August, you'll see a dip in caseload numbers. And the reason for that is we are implementing continuous coverage for children. This is mandated by federal law that came out in December, that states were to do this by January 1, 2024. In Kentucky, we decided to go ahead and implement that as part of our unwinding so that any child determined eligible during our unwinding period will have access to that 12 months continuous coverage. So we pushed a lot of cases that had children in them to later on into the unwinding period. So that's why you'll see a little bit lower number than we first told folks about. So here's May. You know, the numbers look a little scary. We were able to approve to continue 37,182 individuals. This is all at the individual level. And we unfortunately did disenroll 34,124. The unfortunate part of this is the large number of those 24,720 or for other reasons, procedural reasons. They either did not respond to a notice, and by notice that could have been a request for information or a renewal packet, depending on what category they fell into. Most nursing facility members are what we call an active renewal and receive a renewal packet because it requests a lot of information about resources and assets that are taken into consideration for that long-term care eligibility. We did have a large number. We are digging into these numbers of those who have been disenrolled so that we can ensure that perhaps they already have employer-sponsored insurance. We're tracking them also as to whether or not they go out and take advantage of a qualified health plan and advanced premium tax credit on Connect, the state-based exchange. You know, we certainly, one of our goals as part of this is to make sure that people just stay covered. If it's not Medicaid, it's something else. So we're going to continue to follow these folks and make sure that we do know that they have coverage somewhere else. We did have 2,698 pending from May renewal. We're still working through those. These are individuals that cross over, that had a request for information that crossed over the May 31st date, or had a caseworker action pending. And so though they may still have the May 31st renewal date, they are quickly being worked by caseworkers to finalize those. You also see that I have a metric here reinstated within 90 days. Right now it's 0. But what we're also tracking is, as part of the unwinding, any member who within 90 days of their termination date, if they're able to provide that information or verification, we can reinstate them back to their termination date with no gap in coverage. So this is also an important period of time that we're working really hard to reach out to individuals who were terminated to make sure they understand they could still take action and become determined eligible and not have any gap in coverage, which is great for the member and great for the provider, because then there's services they may be delivering can be covered. So we're going to continue to follow those individuals up within that 90 days. Both the state and the managed care organizations, although this doesn't necessarily apply to nursing facilities, but the state and nursing and managed care organizations are calling and reaching out to these individuals. At the beginning of when the May renewal started, we have called every household about 3 times. So, you know, every effort is happening to make sure that individuals understand what's going on and they're subject to a renewal. I did want to talk a little bit what wasn't in the numbers in that last slide. We did decide before the end of May to extend some individuals, about 6,669 individuals we extended to the end of June. We took this action. They are primarily what we consider most vulnerable individuals, nursing facility, waiver. We had some Medicare savings plan individuals. That's what the MSP is. We did decide to go ahead and extend them because they were in the process of going through the redetermination process, and we did not want them to lose coverage without having a redetermination. So you all might see within your facilities someone who was originally a May 31st renewal now will be a June 30th renewal. Because we have pushed those cases, and we are tracking these to make sure they can get completed in time so that that determination can be made before the end of the month. These are June and July renewals. As I mentioned, we've got, you know, several months going on at one time. So we do have, this is at the case level, 79,555 cases that are due for June 30th. Of those, you see the distribution between passive and active. Just a reminder, passive are the ones that we can go out and likely be able to perform the redetermination without the member having to take any action. We ping the federal hub, which has all the information on it that we would need. The active cases are a lot of the nursing facility cases where we have to send that renewal packet. So of those active renewals, because they have to take action, we have determined 31,000, almost 32,000 eligible for June. And then as you can see there, we've got 991 that have been determined ineligible. For July, 48,473 cases subject to renewal for July 31st. Again, the distribution between the passive and active cases, there is a smaller number, mostly because it just depends on the case mix for each month. But of those for July, we've already had 209 active renewals completed. Of those, 162 determined eligible and 19 determined ineligible. So those are the numbers for that. And this just really highlights just how much work is going into outreach for our members. This is a snapshot for June and July. You see, we're doing a lot of email messages. In addition to phone calls, we've done over 94,000 calls to households as a part of the renewal effort. And then we've received a little over 38,000 calls returned that have come in as related to renewals for the months that are in a renewal process. And, again, just trying to track individuals and make sure that they understand what's happening and can complete that redetermination prior to the end of the month. So, we're continuing to work on the nursing facilities, working closely with facilities that might have a large volume of cases. If you're one of those facilities that you're a little concerned about your patients being able to complete those redeterminations in the time span, definitely reach out to us. You should make us aware of that. We are trying to provide some additional support to facilities in helping process, collect the data, collect the information, necessary information, and submit that renewal packet so that we can make a redetermination. So if you do have a high volume, do not hesitate to reach out to us. We are here to help support you all just as much as we appreciate you all supporting us by working with your patients to get those completed and submitted. Just a reminder this is waiver participant specific information, but it includes information about the clocks report that is now available, the Kentucky Level of Care System report available to nursing facilities. It's your way to be able to pull information out to see when your patients are up for a renewal. So don't forget that that's out there and available to you. The way you do that is this sort of shows what the dashboard screen looks like and how you can find where you can pull that renewal report. If you have any trouble pulling that information, make sure you're reaching out to us so we can figure out what's going on. It is a system, and like humans, it's not always perfect. But we want to be aware if you're having specific issues with it. Just a reminder of flexibilities. Some ended, some are continuing during the unwinding, and some have been permanently put in place. A couple applicable to you all. We did end the nursing facility $200 per diem add-on for COVID. We have extended the long-term care resource disregard through the unwinding period. Something we permanently implemented was that nurse aid use of an I-9 instead of Social Security card. All of this is posted. We have a more comprehensive flexibility tracker on our website. So if you're really interested and bored and have nothing to do, you're welcome to go out there and check that for all the different ones. We're particularly notifying providers to make sure that if you've performed any services through telehealth, the non-HIPAA platforms may no longer be used after August 9th. This is not our decision. We have no discretion in this. This comes from the Office of Civil Rights with the Department for Health and Human Services. They get to make those decisions, and they're requiring providers to come into compliance by August 9th. So if you've been using FaceTime, one of the non-HIPAA platforms, which we understand is an easier platform to use for some individuals. You just need to make sure that you're moving to a platform that is HIPAA compliant. Our understanding is a lot of those platforms are attempting to get into HIPAA compliance because they know it is being utilized by across the country by a lot of providers. So just make sure that you all are staying up to date on utilization of that for anything that you're doing through telehealth. I wanted to note, we have 2 pending flexibilities that we've requested CMS to extend. We submitted the request way prior to the end of the public health emergency on May 11th, but we haven't received formal approval from CMS. I'm optimistic we're going to get approval. I'm not sure what the delay is. We keep checking on it every week. But those 2 that we are extending through the unwinding period include that increased bed hold days from 14 to 30 days as well as that 75% of the facility's rate for the bed reserve reimbursement. So we'll let the facilities know once we get the final approval on that. We did ask for it to be effective May 12th, so if there's no gap, because we've requested that effective date, there should be no issue with continuing to pay you all and to cover it while it's pending approval. We're allowed to do that. So we'll keep you guys posted on that. And just a reminder, we have a website with a lot of information on it. We post everything through social media. If you've not liked us or are following us on either Facebook, Twitter, or Instagram, please do that. You don't have to do all three, just do one. We post the same information. We do have ongoing stakeholder meetings. The next one's tomorrow. We're having one a month, and the next one's tomorrow. It's the third Thursday at 11. If you're unable to attend, it'll be recorded and posted, including any questions that come as a result of that. And that gets posted on our website. So that is Unwinding in a nutshell. Happy to take any questions, as a result of that.
I'll throw out the first one. Obviously, the report that you gave was basically Medicaid in total. Do you have any specifics on, nursing facility renewals that are getting kicked out or pending at this point?
Apologize, I don't have it down, excuse me, at the subpopulation level. I'm happy to get that data for you.
Well, I think we would appreciate it. That way we've got an understanding of what's going on with obviously our membership and our providers. I mean, overall, we appreciate, the data and the information, but if it could be drilled down specifically to us, it would be greatly appreciated.
Okay.
Any other questions?
Veronica, this is Wayne Johnson. Quick question relating to the issue that you just ended on. You sounded optimistic that CMS would approve the increase to 30 days and payment at 75%. And we really appreciate you doing that. I don't think that was something that we had sent to you asking for, but we appreciate you going ahead and doing that. My question is, I think I heard you say that providers can continue to bill for those pending CMS approval. And you mentioned that you're optimistic. Obviously we wouldn't want to have providers in a situation where there would have to be a take back if they, build those. But on the other hand, if you do feel that you're positive that might be approved, we'll definitely get that out to providers, because I know that has not been broadly broadcast at this point.
Yep.
But I did want to follow up with that.
Yeah, we because we did not really discuss this with you all, it was something we decided to take forward. That's why we've not broadcasted the information yet. But it is always a risk. I'm going to acknowledge it's always a risk that, we don't get approval. And if that's the case, then we would have to go back and recoup based on that. So that's about all I can really say in terms of any, anything definite. But this is a flexibility that's allowed to be extended. And so we're just, my guess is that CMS has been flooded with these types of extensions that, across the country. And that's the reason why it just hasn't been approved yet. But certainly that's about as definite as I can get. So there is always a risk. And, I think the providers will just have to make that decision if they want to take on that risk of a potential recoupment.
Yeah, and that's what I was going to state. What we may do is just broadcast that out and let each, business decide what they want to do, whether they want to just wait until they get approval or go ahead and bill. But that is good information. I appreciate that.
You're welcome.
Absolutely.
This is Sarah McIntosh. Just a quick question on that same subject. With those, you said that facilities can still bill but aren't there bed hold limits in the system that wouldn't allow them to, or has that been left open?
That was not, and I could be wrong, but that was not supposed to be unwound as part of the unwinding of the flexibility. So we had left that in place. I'll go back and verify that, but it was not something we requested that it return to pre-PHE, pre-public health emergency.
Hey Veronica, it's
Policy.
Pam. We did not do that one. So
Thank you.
if a provider has, if something happens and somebody were to bill and they have a denial, I'll be more than happy to look at it. But it was one that we left in place and did not unwind that.
Thank you, Pam.
You're welcome.
Thank you.
Any other questions? Great. We'll get
Thank
back
you.
to you then as we can drill down to more nursing facility, long-term care patients to see where they fall.
I appreciate it.
Okay,
Thank
you're welcome.
All righty. Item C on the discussion is the MDS Section G crosswalk. Any updates on that at this point?
Steve Bechtel again, Chief Financial Officer. We do not have any updates at this time on that matter. We're still researching and analyzing the various options to address the issue that you all brought up with the schedule, with the Section G. So we're trying to figure out how we, what is best practice for us when we're transitioning to the PDPM on 7/1 of 24. But what I can tell you for sure is that we will do everything possible to avoid the need of facilities completing an OSA. That's our goal is to not require or not to do anything that would require the completions of the OSAs. MDS rugs, as most of you know, it'll be stopped. CMS stopped supporting that, I believe, on 9/30 of 23. And those rugs from the 9/30 of 23 are used. We use those to establish the January through March 2024 rates. So your rates from January through March should be okay under the rugs. What we'll have to do with the 7/1 transition to PDPM, we'll probably have to freeze those rates. We can freeze those and maybe do some type of an adjustment for case mix or some type of like MEI index type of change. And we're still trying to figure out what we can do there. But so right now, though, the rates that you get for January through March will be the same rates for April through June. That's the only thing we can do without requiring an OSA being filled out. So we're trying to do the best we can and the least administrative burden on your all's side, but at the same time trying to address how we appropriately go over to the PDPM process.
So basically, with that April through June quarter being frozen, something will be in place by January 1 to capture January through March to set the July rate. Correct?
Yeah. We're hoping to have on the July 1, we'll be switched over to PDPM at that time. And so hopefully we'll have that transitioned over.
Okay.
Yep.
Do you know, are they trying to use our method or something similar, or have they got other state methods that they're trying to look at as well?
That's what we're currently waiting on, is to look at what the other states are doing and what they've done to try to compare. Our biggest concern is those therapies, that's, what we can do to get it approved through CMS. But that's, we're looking at different models. We're considering your all's approach, but we're also looking at maybe a model of looking at adjusting for state specific MEIs or, state specific weights and things, but those are just a couple options. And then we're trying to see what other states did too when they transitioned.
So all that gets evaluated. Somebody's going to start going down a path. Are we going to be included when we're going down that path? Or is it going to be, we'll come up with a method and we'll let you know what it is?
Obviously, we'll keep you all apprised of that. I'll,
I'm just, I guess what I'm asking is it gonna be a collaborative and working to the solution, or is it really you all have got to go off and, I know you all have got restrictions and rules that you have to work within, and I'm just trying to understand so we can set an expectation.
no, we'll work with you guys. I don't think I've ever not been transparent with anybody on this call. So I will definitely work with you all. I mean, it won't be a surprise.
Okay,
You know, I've been, and I have had many discussions with Wayne, telling him some stuff, you know, as we're going through, but, you know, I'll continue to keep Savannah apprised of those discussions going forward too, so that we know, you know, that we're keeping the association involved.
super. We appreciate it very much.
Okay.
Good.
All right.
Any other questions? All right. The next item on the agenda is the inaccessible asset policy decision. I know we've had on the agenda for several meetings, this issue basically with guardianship and the inaccessible assets. Any updates on that particular item or any decisions?
There's no decision to make any policy changes at this time.
Anyone have anything further on that agenda item? All right, next item is polypharmacy data set feedback. Is Raina Van Gilder or someone on the call to give us an update?
Yes, this is Dr. Barber. I'm on the call, and
Dr. Butler, thank you.
thank you for giving us this opportunity. I'm gonna share my slides. Let's see if so just a reminder that we came up with this Kentucky Medicaid Polypharmacy Initiative by DMS because we all realize and know that polypharmacy is a huge issue in our seniors, and which requires a team approach. From providers to facilities to the DMS, we all need to work together to reduce the pill burden, because all these medications are associated with increased risk at certain stage in life, and then increased risk of falls. There is increased risk of, for example, osteoporosis with protonics. And then most importantly, in our facilities, it takes precious time of staff away from the elders because they are busy in doing med pass. So we in this initiative, our goal is to develop a resource where we can help our facilities in addressing this issue in a collaborative fashion. So in this IRB approved initiative, we have reached out to our facilities. We had a handful of surveys because we email questionnaire and then we interview to the folks who participate. So we had a handful of participants. There are challenges. The biggest challenge, which seems like is time, because of, as a geriatrician, I know that what you all go through, that there is so many things going on, including a survey. So we are again back to seek your feedback in this regard, that how can we, while we are trying to figure out to develop a resource, that what you all feel like, that what else can be done in an issue which we all realize and identify that this will improve the quality of life for our seniors. But unfortunately, there are so many variables and facets to it that we are not able to put all the pieces of this puzzle together. In our last TAC meeting, a question was raised about the hospital, and that is also an important part, especially with, I am as a geriatrician, I'm seeing with antipsychotics. So we are also trying to figure out that how can we reach out with the hospitals. In Louisville, I have reached out to our hospitals and have tried to increase the awareness that these antipsychotics on discharge, they should evaluate the residents and only send those residents who really need that. Similarly, polypharmacy, but on the other medications, their response is that they continue the home medications. They try not to add any new medicine except the antibiotics. With in my facilities, I have increased awareness for the staff that if anybody comes on risperidol or a Seroquel, which is not a home medication, then maybe we need to address that with me and with the providers. So we are working on that too. But if I also want to thank Wayne and Lisa Biddlepuffer and Tim Vino, and they've been very helpful. We have seek their information right from the onset and try to develop this initiative with their help. But we are out here just to get your input, to get your advice that how can DMS can be a resource and in addressing this matter. So please feel free to give any input, any suggestions, any recommendations.
Does anyone on the TAC have any recommendations or comments or questions?
And I would once again stress that there are already too many regulations on the facilities, and our intention is not to use this as another thing that where we judge facilities. Our goal is only to work in collaboration and in tandem with our providers.
Dr. Barber, I don't think your slides were moving while you were talking, if you want to kind of click through them.
Oh, sorry. So yeah, let's see. Yeah, so sorry, I didn't realize that they were not moving. So this polypharmacy, as I just said, that was usually this 5 or more medications, but in our definition, we feel if there are 9 or more medications, if a resident is all that, it's they qualify for a polypharmacy. As I mentioned, increased med pass, that is, in my facilities, I see that the staff are busy in crushing the pills and mixing with applesauce and giving to the staff. So this is, I think that it really takes a precious time away. We want to understand that what with deep prescribing, that through this project, that what are the successes and the challenges which the facilities are facing, because there are some facilities that were able to do a better job on it. The other facilities are still struggling. And then in the end, to collaborate and create a polypharmacy resource that long-term care facilities could find useful and can assist them. So similarly, psychotropic medications, as I just mentioned, that's a big guidance. Surveyor compliance guidance also, that down the road with psychotropics and the challenges which the facilities face, because sometimes we see like that, especially these days, the surveyors that I think OIG is also short on surveyors. There are new surveyors coming in and they need some guidance in that regard. So in the end, if you all feel any of your member facilities, if they are interested in participating in this initiative and want to just, we can email them the questionnaire. Dr. Rena Van Gilder, her email is there. If you feel like that there is any member is interested in participating in the project, please email her. We are exploring ideas of engaging hospitals. If you all have any suggestion in this regard, please feel free to let us know. So we are out here as a resource, because the polypharmacy gonna be a issue we need to keep on addressing that. just before this meeting, I had a conversation with a family on a senior that was like 90-year-old. I discussed with the families, and quite honestly, in my experience, it's the lack on our part, the providers, the facilities on reaching out to the families. Majority of them, they are reasonable and they agree on reducing the pill burden. So please, I know your time is precious. So any feedback, anything comes up, please email us, and we will continue to give you guys an update.
Yeah, I think working with Lisa and Wayne and Tim Vino with their respective memberships, they can identify the individuals that could participate and work with you in this initiative. We appreciate the update.
Thank you. Thank you, Terry.
Wayne, my notes aren't real good on number F. I'm going to throw that out to you if you would.
Yeah, I think, sorry, I had to unmute myself. I think number F really is sort of the same issue with item E with the polypharmacy. I just was curious, the reason we wanted to have that separated was in discussions, I think, with Dr. Babar. Previously, we wanted to, which he had on his slide, he asked the question, how can we, any ideas on how we can communicate with the acute care providers to reduce that issue. So I didn't know if either Rainer or Dr. Babar had an update on any discussions Medicaid has had with acute care regarding, the need to reduce medications. But that's it.
All right. Anything else on polypharmacy or the hospital medications on discharge? All right. Any other issues that need to come before the TAC? I think our next meeting date is scheduled for September the 13th. And unless there are any other issues, I think we stand adjourned. Thank you for your participation.
Everybody have a great afternoon.
Thank you.
Thank you. Bye-bye.